Welcome to the Explainer. Today, we're breaking down a bacterium that is a true master of disguise and a constant headache in the clinical lab, Aeromonas hydrophila. Using a comprehensive Gemini deep search, we are going to get into all the details that microbiologists really need to know, from its incredibly tricky identification all the way to its deceptive resistance patterns. Okay, so let's just jump right into the single biggest challenge in modern Aeromonas diagnostics. What you're seeing on that culture plate, or what your biochemical panel is telling you, well, it might not be the whole story. And believe me, that distinction can have some pretty serious clinical consequences. So here's how we're going to tackle this. We're going to follow a path right from the lab bench to the patient's bedside. We'll start with its tangled up taxonomy, move through lab identification, then we'll explore the diseases it causes, wrestle with its complex resistance, compare treatment guidelines, and finally, wrap up with prevention and control. First things first, we have got to understand the identity crisis happening within the Aeromonas genus itself. And this isn't just some academic debate, It directly impacts how we interpret what we're seeing in a clinical isolate. The identity of this organism has been a moving target for decades. What started as just a single genus back in 1943 was revealed to be this massive complex of different species by the 1980s. This isn't just a history lesson. This is the very reason why identification is such a headache today, with more than 30 species muddying the waters. And this right here, this brings us to a classic trap in the lab. Your routine phenotypic tests, whether it's an automated system like the Vitek or a manual strip like the API 20E, often just can't tell the difference between Aeromonas hydrophila and its much more virulent cousin, Aeromonas dhakensis. Misidentifying this is a serious problem because dhakensis can be far more aggressive. This is exactly why molecular sequencing is the only way to be sure.
All right, let's head over to the bench and walk through how we actually get a definitive identification, starting with the basics and working our way up to the gold standard. So on a gram stain, Aeromonas hydrophila looks like your classic gram-negative rod. The key thing to notice, though, is that they're straight rods, not curved like you'd expect to see with Vibrio. And that single polar flagellum is what gives them their motility.
Now, this is where it gets really fun, because its growth on common media can be both a huge help and incredibly misleading. On blood agar, that strong beta hemolysis is a great clue. But then you look over at the McConkey plate, and it can look exactly like E. coli, which makes doing an oxidase test absolutely non-negotiable. Its poor growth on TCBS, though, is a great way to help rule out Vibrio.
This is how we get the final, definitive answer. To cut through all that taxonomic confusion, we have to go molecular. Your standard 16S sequencing just doesn't have the resolution to do the job here. The real gold standard for telling these species apart is sequencing housekeeping genes like GYRB and RPOD.
Okay, so we've got our ID. Now, what does this bug actually do to people? Well, it's a versatile and, frankly, sometimes vicious pathogen. Yeah, gastroenteritis is the most common thing you'll see, but you cannot sleep on its role in some really nasty skin and soft tissue infections, especially after any kind of trauma that involves water. When this bacterium goes from a localized infection to an invasive one, the consequences can be absolutely dire. And this number, well, it's a pretty sobering reminder of what's on the line. The mortality rate for Aeromonas sepsis can top 46%, particularly in patients who are immunocompromised or have underlying liver diseases like cirrhosis. All right, here is a clinical pearl you absolutely need to know. Aeromonas hydrophila lives in the gut of medicinal leeches. So what does that mean? It means any patient getting leech therapy, which is common in plastic and reconstructive surgery, is at a super high risk for a serious infection if the right antibiotic prophylaxis isn't given. This next part, this is probably the most critical section for anyone in clinical practice. We're talking about its complex and often deceptive antimicrobial resistance profile. This is where the lab can accidentally lead you down a very dangerous path if you're not paying attention. Aeromonas hydrophila comes armed for a fight right from the start. It typically carries 3 different chromosomal beta-lactamases, giving it intrinsic resistance to a lot of penicillins and early-gen cephalosporins. But it's that last one, the class B enzyme CphA, that's the real troublemaker. And here it is, the CphA Paradox. This is something every single microbiologist needs to have burned into their brain. Your lab report might scream susceptible to Carbapenems like meropenem, but it can be a dangerous illusion. In the patient's body, in vivo,
that CphA enzyme finds the zinc it needs to activate, and the drug can fail, even when the lab report said it should work. So because of this whole paradox, you have to be incredibly strict with the breakpoints. And look what's missing from this list. You see that? EUCAS provides no safe clinical breakpoints for Carbapenems when you're dealing with Aeromonas. Trying to use breakpoints for Enterobacterales is a really dangerous practice. Okay, so with all that in mind, how do we actually treat these infections? Let's compare two major sets of guidelines, the Dutch SWAB guidelines and the international IDSA recommendations. The difference really comes down to philosophy. The Dutch SWAB guidelines favor de-escalating to a targeted monotherapy like ciprofloxacin once you have Aeromonas confirmed. The IDSA, on the other hand, recommends empiric combination therapy right out of the gate, especially for wounds associated with water exposure to cover other potential bugs. Let's zoom in on the Dutch guidelines for adults. They recommend targeting the infection with either a fluoroquinolone, like ciprofloxacin, or a third-gen cephalosporin, like ceftriaxone. The whole idea is to hit it hard with broad-spectrum therapy at first, then scale back to a targeted drug as soon as you have your ID and susceptibilities. Now, for kids, the story changes a little bit. To avoid using fluoroquinolones routinely, cotrimoxazole is the preferred agent. But for severe infections where other options aren't great, ciprofloxacin can be used, and ceftriaxone is another strong alternative. And finally, how do we stop these infections from happening in the first place? Since it's pretty much everywhere in water, the focus has to be on managing environmental reservoirs and high-risk procedures. Prevention really boils down to three key areas. First, strong hospital water safety management to stop biofilm from forming. Second, just standard contact precautions for patients with diarrhea or draining wounds. And third, and this one is an absolute must, mandatory antibiotic prophylaxis for every single patient undergoing medicinal leech therapy. No exceptions. So from its confusing taxonomy all the way to a resistance profile that's downright deceptive, Aeromonas hydrophila is a bacterium that demands our respect. The ultimate takeaway is this: always question the initial phenotype, trust your molecular methods, and whatever you do, do not be fooled by a Carbapenem MIC. For a complete list of all the sources we used in this Gemini Deep Search, you can check out the linked notebook. If you found this useful, subscribe for more microbiology explainers and let us know in the comments what's the trickiest organism you've had to deal with in your lab.